to quickly transition because we've got a lot of good information to share for the rest of the hour today on connecting patients and caregivers with community-based organizations. And as you can see the title there, it says a CPES Model Success Must. And it really is a must that we do this. And so that's why we're focusing on it this month in all three of our Wave 1, 2, and 3 PACP calls. Because as you know, last month we focused on what we're calling our stretch goal of getting at least 70% of all of our patients enrolled back to the 7 to 14-day clinic visit and getting the e-care plan. And now we have to, that's a good segue into taking it to the next step and making sure that we get the patients connected with the resources, whether they be medical referrals or whether they be community-based resource referrals, that we actually get the patient to the appropriate resources. So that's what our goal is today, and we're going to focus on two of our high priorities, great partners from the very beginning of CPES and have been partnering with us all along the way, and that's the area agencies on aging, or the AAAs, as you'll hear me say. And that's not the CAR support service, but that's the older adult support service, the AAA, and also our enhanced pharmacy network services. And I believe I just saw Dr. Skip Cummings join the webinar. Thank you, Skip, for all of your leadership. And I'm going to turn over, we're going to have the enhanced pharmacy services first. I'm going to turn over to Dr. Tracy Simmons-Cornegi. She is with the Community Care of North Carolina Pharmacy Network. She's the director down in Eastern North Carolina, and Tracy has been working with us in sites down in Eastern North Carolina, but also has been a great resource to our team and to me personally with making sure that we are including the CPNC network in all of our site visits when we came out to launch our site, and that we are keeping them informed. Dr. Cummings has been doing that. He's had a couple of meetings with the CPNC network directors now to keep them informed and updated on CPES. So I'm going to turn over to Tracy, and then she's going to share with you some important reminders about these enhanced pharmacy services, and then we're going to have a really good example by Tracy and Dawn Becker from Lenore Memorial Hospital of how they work together on a monthly basis to improve outcomes.
Thanks for the introduction, guys, and hope everybody's having a good day throughout the state. It's pretty here in Duplin County today. So we will just sort of give you guys an overview of CPESN, which stands for Community Pharmacy Enhanced Service Network. And so we want to think about why involve community pharmacy. And so as you can see from this busy graph here, this was taken just from a subset of patients that CCNC, or Community Care of North Carolina, manages. And these are what we call our Medicaid patients, or our dually eligible, so they have Medicaid or Medicare. And so as you can see, just from all of the CCNC enrollees, most of the patients see the pharmacy twice as much as they see the primary care provider. And then as you move across the continuum, it depends on, as the patient becomes more high risk with multiple chronic illnesses, you'll start to see that they would potentially see the pharmacy quite a bit more than they would see their primary care provider or even specialist as they become more complex. So I think it's a good place to reach in and to bring in the community pharmacies into our interdisciplinary team as we move forward. So within that, back in 2014, there was a group of community pharmacies in the state of North Carolina that sort of came together to create what we call the CPESN network. And it was the pharmacies who are willing to provide enhanced services and help coordinate care across the healthcare team. So it officially became a network in April of 2014, and currently, as of the end of December, we had 277 North Carolina community-based pharmacies. Majority of these are retail pharmacies, and this is an open network. So at any time, if you guys, as you guys listen to this presentation and identify some community pharmacies who may not be part of the network, you know, please share those names with me or my colleagues across the state, and we would be glad to, you know, follow up with them to see if they would like to become part of the network, because it is an open network throughout the state. So a little bit more about CPESN, and what it is it's sort of trying to move from the conventional things that we think about a pharmacy doing more to providing more outpatient services, you know, really looking at how do we help decrease total health care costs, how do pharmacies help reduce ED visits and inpatient visits and work on those potentially preventable readmissions. And so through some ways of the services that these pharmacies provide are through home delivery that they may provide for our patients, especially in some of our rural areas across the state. Also, they have some med synchronization programs in which they would be able to fill all their meds at one specific time of the month, especially if there are some financial hardships the patients may experience. And that also does help with the home delivery side. Some of our patients do benefit from adherence packaging, and there are different forms of adherence packaging that the pharmacies may provide, so it would be good to check with those. Some charge, some do it free of charge, so it just depends on the pharmacies and what services. And also there are some broader services that some of the pharmacies may provide as well that you would be able to identify in the Locator app that is available, that is, and we'll provide that later on, which it is available on the internet. And those broader services could be some pharmacies provide vaccinations. Some pharmacies may have naloxone prescribing. They do DME equipment, maybe smoking cessation or nutritional counseling. So there's some other broader services that you may find. But the three that you see here that are listed as examples are typically what most of the pharmacies do provide throughout the state. So here's a little bit of a busy slide talking about it. As you see in the top left corner, you'll see the map of the CPESN pharmacies, of those 277 pharmacies throughout the state, where they're located geographically. And then in the bottom right corner, you'll see the state of North Carolina again. It looks like it's divided into 14 networks. I am one of the network pharmacists for one of the networks, which is the Eastern, which is the light Carolina blue color. We cover 27 counties out here in the East. But I do have counterparts throughout the state, and there is a contact list of the network pharmacists that Rico will share with you guys so you can have it at hand, and it also includes our contact information so you can just give us a call. So with this, you know, looking at, again, we talked on the previous slide, the adherence packaging, med synchronizations, mission immunizations. So with these CPESN pharmacies, they do work very collaboratively with our, currently our CCNC model with care management to help provide more enhanced care coordination that we need. These pharmacies do take referrals, so if there is a patient that is in a specific area that may not be using one of these pharmacies, you can make a referral to these pharmacies, and there's a referral form that can be used, or you can just give them a call, and they would be glad to work with that as well based off the needs that are being needed by the patient. And some examples of maybe reasons to send a referral is if the patient maybe has poor understanding of their disease condition, they need more disease management. If the patient's using multiple pharmacies, multiple providers, more for that polypharmacy, that we can get them using one pharmacy, and that pharmacy sort of helps manage and helps those providers with that. And some of our patients do have very complex medication regimens. So really doing a thorough medication reconciliation, med review after a patient's hospitalization, and ensuring the patients are getting those meds. And there could be other things. We mentioned earlier about delivery services. You will see some of our patients have to pay people to take them to the pharmacy, or they can't get to the pharmacy. So that delivery service we have seen has been is a very good option that some of these pharmacies provide for some of our patients to really help with improved medication adherence. So I mentioned briefly about the team collaboration. So there has been times when one of the pharmacy staff may do a joint visit, maybe with you guys as part of this project, or with our care managers, helping with that and actually looking at some of the meds and going over with the patients there. So it just helps with that team collaboration. We want to look at how can we prevent barriers for medication that relate to medication adherence. A lot of times we do see with our patients, especially in this population, med adherence may have been some of the reasons that may have led up to having a stroke. So how can we ensure that they do get their meds and they are taking them correctly so we can prevent maybe a follow-up ED visit or a readmission that we may have. So just remember also there is care management as part under CCNC as well for your Medicaid and dually eligible patients that you can make referrals to as well. So there is a CPESN Locator App that is available. I will include the actual link for that on an email to Rika when she sends out the contact list, so you guys can get that. But I will tell you, it's the address is locator.cpsn.com. Again, locator.cpsn.com. And if you do look at that, now CPESN has rolled out to be CPESN USA. And so you will actually see other states now that are participating in this project. And so you would just click on the state of North Carolina, and then it will take you to here. And so on the screen that you see here in the middle, it says enter or search criteria by pharmacies. So you could potentially type in a town, let's say Greenville, North Carolina, and then you can put within a mile radius, 5, 10, 15, or 20 plus miles. If you click 20 plus miles, that's going to give you all the pharmacies in the state. So you may want to narrow it down to 5, 10, or 15 miles, and then that'll give you more in that area of that town. You can just click search after that over on the far right, and once you click search, it will just bring up the name of the pharmacy. If you want to shorten your search based off of, is it DME billing, is it home delivery, is it adherence packaging, as you see in the middle of the screen here, you can also do that as well. And then it'll bring up the pharmacies, and then you can go in and see what services those pharmacies provide, sort of the broader services as well. You'll see a green check mark, or you'll see a red X that tells you if it's those services or not. So just any questions about CPESN? I think there's a good place for these pharmacies for some of our patients throughout. And again, with CPESN, it's any payer. It does not have to be just Medicaid or Medicare for adherence packaging or some of the other services that they may provide. It can be for any payer. So just keep that as a reminder.
Tracy, this is excellent information. I know that we shared some of it depending on your site, but we didn't have, well, Tracy, you were at the table with Lenore from the get-go, but we didn't have in wave 1, we didn't have as much pharmacy representation as we did with wave 2 and 3. So hopefully either this was a great reminder for you or maybe even some new information. So we very much appreciate your sharing this information with us today. And I'd like to ask for Dawn Becker, the post-acute coordinator for Lenore Memorial Hospital from Wave 1, to share, and Tracy, you can jump in along with Dawn, to share how you two are meeting on a monthly basis, at least by phone call, on behalf of your patients to improve their outcomes And I know Dawn probably will give you a great example of how right after her site-specific visit and she launched, how she had to call Tracy in, and how pharmacy was a critical piece of taking care of one of her patients post-discharge. So I'm going to turn over to you now, Dawn.
Okay. So when we had our site-specific visit, Tracy was there and we were introduced, and I was still trying to wrap my brain around this whole thing and how it was going to work. And a day or two, it seemed like later, I got a phone call from Tracy, and she said, "Let's meet. Let me come to your office and I'll meet." And I was like, "Okay, whatever. We'll meet and see what we can do together." And so lo and behold, I think he was our first patient, maybe our second patient. He was a gentleman that uses the VA for his primary care, and he was blind. And so got him all enrolled, sent him home, and as part of our program, we have a community paramedic who makes a 2-day visit at their home. And I got a call from him, and he said the patient cannot get their medications. And I said, "What do you mean? He goes to the VA, he should be able to just go pick up his medications." And he said, "Well, he had an appointment, but the VA clinic canceled it, and they haven't rescheduled him for another month, and they won't fill like a called-in prescription. They have to have a hard copy, and their practitioner has to transcribe it in order for it to be filled." And so we called one of the local pharmacies, but it would still be close to $400 for his prescriptions, and he could not afford even half of that. So I had Tracy's card, and I said, "Well, let me call her and see if she can help me out." So I called and told her the story, and she made some suggestions, and then in the end she said, "You know what, I'm going to call you back." And the next thing I knew, Tracy called me back with a contact at the VA, a fax number, told me to get the hard copies, fax them to this person, and within about 24 hours our patient had his prescriptions in hand. But without Tracy, I surely would not have been able to navigate the VA situation and get him his prescriptions. And so hats off to her, and I wouldn't have been able to, get through that situation without her assistance. And I guess at that point, or during our first meeting, we had decided that we would at least meet monthly or so, or regularly. And then now we just kind of touch base with a phone call unless there's an issue. But Tracy's been great. She's helped me navigate getting patients' blister packs at different pharmacies, and solving all sorts of pharmaceutical issues. But also she was able to help me get blood pressure cuffs for patients, and she just knows the community so well that she's a wealth of information beyond just the pharmacy services and so forth. So I would recommend tapping into that service as much as you can, because it's been huge for us. That's kind of my story. I don't know, Tracy, if you have anything to add.
Yeah, it's an excellent story, and I think, you all know Dawn well now, and Dawn serves on our implementation committee because she has been able to work very collaboratively with a lot of the community resource network leaders like Tracy in her community. And as she said, we strongly encourage you to reach out to your pharmacy director. If you don't know who that is, Tracy can, I'm sure, also help you connect with that person so that you can have some of these, also these great experiences.
I want to transition now over to two of our Wave 3, your Wave, post-acute coordinators. We have Jennifer Holmes and Wendy Crumpler with us this afternoon from Vida and Duplin. And Tracy has met with Jennifer and Wendy as well to start getting a similar system in place to work with their patients to provide additional support when needed with these enhanced pharmacy services. So I'm going to turn over to Jennifer. And Jennifer, please tell us a little bit about about how things are working there at Vita Duplin.
Hello. I actually met with Tracy back in March, and we met with the pharmacists over at Duplin, and we kind of all came together. And so what we have been doing with any of the stroke patients that come through over at Duplin is the pharmacists are kind of looking there at Duplin at some of the patients that come in to just kind of see what they may be eligible for medication-wise, so they can kind of get started on the front side. So maybe whenever these patients are discharged, it won't be quite as, you know, as difficult to get them set up with everything they need. And so, so right now they are actually working with me and Tracy as well. But the pharmacist over at Duplin actually kind of, they'll email me if they have anything, if there's patients that are there that they may think, you know, would benefit from any kind of from medication assistance, things like that. And so we're hoping to kind of help the patients before they, when they first come into the hospital, to kind of get a head start on everything. So it won't be quite as difficult on the, once they're discharged, to make sure they have everything they need. And so that's kind of what we're doing now as far as, you know, pharmacy, making sure they have everything. And you know, it's working really good so far.
Thank you very much, Jennifer. Wendy, is anything you would like to add?
No, I would just like to add that we do use this for Compass, but as you know, we also follow all of our high-risk people, and the CCP pharmacists are a great asset for most any patient that we need anything on. They're a great wealth of information and resources, so we're utilizing her and her team for pretty much all of the patients. So I would encourage everyone to tap into that resource for their population.
Tracy, would you like to give just a couple of words about how you've met already with this team early on in their Wave 3 team, and how you have already started the ball rolling with working with this hospital team as well?
Yeah, I'd be glad to. So a little bit about Vita Duplin, and actually Duplin County is my home as well, so it means a lot to me in this area. And so they are part of Wave 3, and I did attend their initial meeting there as well. And so I think Wave 3 was like the end of November. And so the 1st of January, so I reached out to Jennifer Holmes, who's the stroke coordinator, compass coordinator. And so we just had some meetings to talk through some patients and how they're sort of processing patients, and just thinking through that way with them, and come up with some ideas for some of the first couple of patients that they have had. We had a subsequent meeting that I actually involved the inpatient pharmacy team at Vita Duplin to help them identify some additional patients. Because of course in the hospitals, the pharmacy team knows which meds are being dispensed and who's getting what, and if they've got to replace them in the ED or in the PICSs. So we actually met a couple weeks ago and have involved the pharmacy team, starting to also help make referrals to help with identify patients because of the workflow process that's at Duplin. So, just because limited pharmacy resources, and I would encourage you guys to talk with your inpatient pharmacy teams at your hospitals to see how they have a part in this. And so at Duplin, talking with Lee Gurley, who's the pharmacy director there, they are aware of CPESN and others, and so they are part of that, identifying if there's any needs, and are looking at the patient's meds while they're on admission, and thinking about planning for discharge or what they're going to go home on, just to ensure there may not be any issues with their medication. So the inpatient pharmacy team at Duplin has become part of their team as well with that transition.
Wonderful. That's a great additional comment, Wendy. And, we tell you all when we come out and went well in boot camp, and then we share with you when we come out to your site-specific visits and your training there, and we share with you at that point and all throughout when we have our monthly individualized conferences. We're always reminding, parts of this model are very stroke specific, but parts of it really can be adapted to any other chronic care management patient. So I'm so glad that Wendy and Jennifer, that you all are using this great service for your other patients. And I know that Dawn probably would echo that because pretty soon after starting the COMPASS model with stroke patients, her hospital was already looking at using the model with CHF patients as well. So excellent additional comment there.
So in the sake of time, we're going to segue over to I'm going to give you I'm obviously not Blair Barton Percival, but I'm going to speak on his behalf as well as Teresa Jackson, who is the family caregiver specialist. Some of you have met Blair and Teresa at boot camp and at site-specific visits and heard them speak. But I want to just give you a quick reminder of what the area agencies on aging do. They've been around for a long time, about 40 or 50 years now, and so have a lot of experience helping the more vulnerable older adults be able to stay at home and in their own communities where they're healthier and happier, and that's what we would all desire. So we very much appreciate these agencies and their services. We pay taxes that allow us to have these agencies across the state. They get funds from the federal, state, and local levels. So, we need to make sure that we are tapping into them on behalf of our patients and caregivers and maybe even your own families. You can see the map here, and you can see where you're located and which region might be supporting your patients and caregivers. There at your sites. We happen to be in Region G, which is the Piedmont Triad Regional Council Area Agency on Aging, and you can see here their core functions, what they do as a regional agency: advocacy, planning, program and resource development, information brokerage, funds administration, and quality assurance, as well as really important training and education for agencies that they work with across the state. They provide some of their services by contract, and you're familiar with the ones listed here for meals, maybe like mobile meals or Meals on Wheels. Transportation is critical, especially in our more rural areas where transportation is not good. You can reach out to them. In-home services like in-home aid services. We have strongly been promoting the use of respite services for our caregivers and families. And then I want to also highlight falls prevention, and I'll speak just a couple more minutes about that momentarily. They also are direct service providers. They have a wealth of information and can refer. So we need to remember that sometimes if we don't know what's available, particularly for older adults, they tend to serve adults 60 years and older. But for some of their respite and other services, sometimes it's younger ages. And if we don't know, we can simply pick up the phone and call them because they have a whole laundry list of referrals. We've tried to get those into your community resource directories that you can pull down from our website, but we're always learning about others. So if you don't find it in your directory, we encourage you to call. Some of these agencies can provide case management and health insurance counseling, and certainly in this time of very complex insurance information, don't hesitate to reach out to get some assistance for your patients and caregivers there. And then the family caregiver support programs. These are really very important, and we've been working with them again since the inception of COMPASS, and we've had a couple of updates with the directors like Teresa Jackson for here in the Piedmont Triad area, and what we hear is we stand armed, ready, and willing to help these families, but we don't get a lot of referrals. So please remember to tap into those caregiver family services as well. This slide is just to remind you about the partnership. that we've had with the AAAs from the beginning to help us to decide the best ways to connect with patients. And they have helped us to get experts to the table in Wave 1, but particularly we learned from you all and did an even better job in Wave 2 and 3 with connecting representatives from the AAAs to local hospital community coalitions. And these are pictures here of Blair and Adrian, the director and the assistant director for the Piedmont Triad Regional Council Area Agency on Aging, and they serve on a number of our committees, our core engagement committee, our steering committee, and our implementation committee, and also have been instrumental with connecting us with patients and caregiver stakeholders that have vetted all of our documents and so on and so forth. I also want to very quickly highlight the Falls Prevention Coalition. There is a national initiative that was spearheaded by the National Council on Aging, but we also have North Carolina regional and local coalitions, and we share with you Ellen Schneider's contact information. If you don't know the Falls Prevention Coalition in your area, you can contact Ellen and she can help connect you with the appropriate people. They have also been working with us. There is the Center for Health and Wellness in Asheville to help connect us with folks at the local levels and with our sites, specifically at their site-specific visits, particularly in Wave 2 and 3, we did an even better job of hooking up. As we know, these patients are at much higher risk for falls, so we want to make sure that we get them into these coalitions as necessary. And I'm going to stop there. We'll have a couple of minutes for questions at the end. I know that was a quick run through, but I wanted to save plenty of time for our Wave 1 post-acute coordinator, Terry Medlin. I'm going to turn over to her next. And then we'll turn over from there to a Wave 2 representative, post-acute coordinator, Rhonda to talk about how they are using these services in two very different communities. Terry out in eastern North Carolina in a large rural county, Carteret County, and then Rhonda talking about how she uses these services in a much more metropolitan area in the greater Charlotte community. So let me turn over to Terry, and when Terry finishes, we'll segue over to Rhonda. So Terry.
Hey guys, this is Terry. I work for Carteret Healthcare based out of Morehead City, Wave 1 post-acute care coordinator. And here at the hospital, I'm actually the transitional care coordinator as well. So we've been working with AAA, or the Area Agency on Aging, for myself personally for almost 3 years. So we're very familiar with what they have to offer our community. Personally, I deal with Tanya Cedars, who's based out of New Bern. And being that New Bern's a little ways away from us, we do most of our communication via email or phone conversations, which is perfect for us. Tanya is wonderful to work with. She is a wealth of knowledge. What we benefit from her are emails weekly about local changes in the community, within the state, trainings that base around community resources and services, and webinars that most are generally free that we can take to gain knowledge about, again, local resources and community services. She also fills us in on long-term care ombudsman, which I'm not sure if you guys are familiar with that, but they basically focus around long-term facilities or home health care agencies. We use them a lot just because a lot of our patients, whether it be just regular discharges from the hospital or if they're in the CPES program, have home health services. So we use her based around what their rights and responsibilities are and what the patient's rights are. If we ever run into any issues there, she's a great resource for that. She gives us information on local services, as Sylvia said, the Meals on Wheels, a lot of transportation services. Being that we are in such a large county, we have a lot of patients who have problems getting to doctor's appointments, outpatient therapy. Thankfully, we do have a lot of community pharmacies that do deliver, so we don't usually run into that too much. But she helps connect our patients with transportation to and from those appointments. They do also senior services as far as activities within the community, new programs that come up all the time with grant funding. She'll let us know what those are, that we can offer those to our patients, whether it just be arts and crafts down to exercise programs, to nutrition classes, things like that. And also they help us with simple things such as eyeglasses. You know, if there's patients that don't have the means to pay for this, any type of DMEs, we have a lot of facilities around here that are volunteer and outreach programs that will offer, you know, simple things as walkers and wheelchairs, eyeglasses, things like that. She can get us in contact with who is currently facilitating those programs. Personally, we use her a lot too for guidance on powers of attorney and living wills. As we know, our patients will go home and not only are we helping them medically and with their health care, but we're also helping them with resources within themselves and also with their caregivers. So a lot of times we run into caregivers needing assistance on power of attorneys or living wills for the patients, or, you know, that respite care that she spoke about, just needing a couple of hours off here and there. And Tanya is really great about getting us, you know, speaking with the patients and speaking with the caregivers in regards to, you know, what services are provided for those patients. So I highly recommend, if you don't know who your representative is for the AAA, to get in contact with them because they are a wonderful, wonderful resource.
Okay, so I would like to transition over to Rhonda Vanny now. She is the post-acute coordinator in your wave 2, for CHS University, and she has some additional helpful hints to share with you. So Rhonda?
Thank you, Sylvia. I appreciate you letting me speak today. I think everyone pretty much knows me now, so I won't have to introduce myself. But I did want to talk about the area on aging. I'm not going to go into all the information because we've had wonderful presentations already on what they provide and their services. But I wanted to speak on some of the things that I see that pop up a lot under the e-care plan resources on the care plans that we give our patients. One of them is the health and wellness. It's the evidence-based program on fall prevention, like Sylvia was talking about. That comes up a lot with our patients falling as often, and you know that they have the potential to fall more so than others. The diabetes, they have help with that. It's also in Spanish and English, and other chronic conditions. So don't forget about those. Also help with the living wills. On our 7 to 14 day clinic visit, the last question we asked them talks about, do they have a living will, and if they don't, or do they want information about it? And that is another great resource that we can provide them. Also, some of the people want to, unfortunately might not want to, but they may need to have some kind of work. As we get older, our retirement might not hold us over as long as we think. So there is some help for the older population to get a skill or be able to go out and be some type of, you know, some employment. And then the transportation is a huge one. There's a lot of times people can't get to and from to get their medicine or go to their doctor appointments, and this is something that they provide. It's free for disabled and older adults. So those are the 4 things on the area on aging I wanted to speak about, and it's a wonderful, I mean, it's so vast. It's you can't even really comprehend everything that they do. So it's a nice thing that they have. The next thing I wanted to talk about was the Community Care of North Carolina. That is the wonderful resource that we can use them, and it's on the e-care plan that we give our patients to. A lot of times our patients don't know what medications they're taking, why they're taking them. They can't open their medications. They don't remember to take their medications. So there's a lot of things that these pharmacies can help our patients do. And help them remember to take their medicines, because, you know, CVS and Walgreens, they don't have that ability to do the things that this pharmacies can do. And I have an example. I had a CPES patient that I found out that he wasn't taking his medicines when he got home, and when I asked him why, there were many issues. One, he had no insurance, or he did, but he didn't know what he had. He had forgetful memory. He had transportation issues, but I think the major problem he had was he spoke Romanian, and he had a really big accent, and he was very, very hard to understand, and I just wonder how much he really understood me too. So he said he just couldn't get the medicines, and it was just too overwhelming for him. So I said, okay, well, let me see what I can do. So I called CVS, and I kind of got this, you know, we don't take his insurance, and, you know, I told him about that. So then I called Walgreens and kind of got the same thing. So I called the CCNC pharmacy, explained the situation about what I was finding with this patient, you know, with all the problems that he had. And they immediately called the MDs, got, you know, the prescriptions and the pharmacy prescriptions, and got everything that they needed to help this patient. And they took the medicines to him. They did the MedRec review. They bubble wrapped his medications to where he could open them easily. They put him in things to help him remember to take them on certain times. So they went over and beyond helping this gentleman be successful in taking his medications. They still continue to take them out to his house every month. So I appreciate that. But without this type of service, many patients would be left to fend for themselves and possibly have poor outcomes. So let me see, I've been talking and I haven't been really doing my slides, so I apologize for that. But anyway, I'm thankful for CPES because they have opened opportunities to our patients, you know, have options that maybe they didn't have prior to the CPES and us knowing about what resources different places offered. And I really truly believe that if this gentleman didn't get the help from this pharmacy, you know, he would be either readmitted with another stroke, possibly could be dead, because he, you know, it's very important for people to take their medicines. So I really thank everyone for that. And the last thing I wanted to talk about was the pharmacy referral form. And that's a lot like what Tracy was saying with the Locator app. It has certain things you check. You know, do you want the counseling? Do you want education? Do you want medication monitoring? Or you know, do they need to review their MedRec? And you check that. You can either email it, you can fax it, or you can even call, whatever you prefer to do, and say how quickly you need it. And so that's how you can communicate to get that help. But that's really about all I had to say, and I appreciate you listening to me, and if you have any questions, feel free to get up with me.
Thank you so much, Rhonda. I'd like to just ask here, we have just a couple of minutes. We have, you can see that we have now up on, if you're on the webinar, up on your screen, contact information for both Terry and Rhonda. But I'd like to see, while we have some of them, Dawn and Rhonda, on live, as well as Dr. Skip Cummings, if you have any questions for them. Well, we thank you again, those of you who presented. We really appreciate your willingness to share your experience and your expertise with your peers. And we appreciate all of you joining this afternoon and all you do each and every day to take care of your patients and their caregivers. And I just wanted to remind you that next month we're going to have a special webinar on caregivers and on the caregiver survey and caregiver assessment. So stay tuned for that. Rika will be sending out later this week some information about that webinar that we very much hope that you will be able to join us in May as well. If there is nothing else in closing, we will go ahead and bid you farewell and have a good rest of your week, and we will be in touch.